Okay, we'll start now. Thank you, everybody, for joining us. My name is Peter Cleary. I'm a principal here at Santis Health, and I'm really pleased to be here with my stellar colleagues from across Canada, Marcel, Harpreet, and Steve. And we're going to talk today a little bit about what happened last week with federal, provincial, territorial health ministers, the status of the bilateral funding arrangements, provincial priorities in health, what this all means, and then a couple other uh, hot health files that will likely come up this fall from an FPT perspective. So really taking a look at this pan-Canadian health policy world, this nebulous space that we at Santis tend to operate in quite a bit. So next slide, please. A couple housekeeping things. So one, there is a Q&A button. You can go in there and ask questions directly. That allows us to give you either a written answer or we'll verbally tackle it at the end. And it also is helpful to use because our broader team is on the line that might know things that we don't know who are on the actual panel here today. So putting them in there is most helpful. We are recording this. We will distribute the slides and everything afterwards. So that way, if you would like to share it within your organization, you're more than welcome to. And then afterwards, we do have a survey so we can constantly improve these webinars that we offer to make sure that they're hitting the mark and also get ideas for different things we can do in the future. Next slide, please. I introduced the team already, but you will hear from everybody. Steve is joining us from out in BC. Harpreet is in Toronto. Both focus on provincial government relations efforts in their respective jurisdictions. My colleague Marcel is up here in Ottawa with me, and we are all very pleased today to lead this discussion. And with that, I think everybody here knows about Santis. I'll do the very quick plug. We only work in health and life sciences. We do a hybrid number of different things, including strategy and management, consulting, communications, marketing, government relations, and advocacy. And I think I introduced that nebulous space, this pan-Canadian health space, that it's always unclear how policy is created or what the mechanisms are to create policy when you're dealing with different governments and at different levels of governments. So we'll try and hit on that today in the best way that we can. So with that in mind, I think it's almost time to flip over to my colleague Harpreet to walk through the current political environment.
Thank you, Peter. So if we take a look at some recent polling to see how Canadians feel about the current political landscape, we see that Conservatives are taking a strong double-digit lead over the Liberals. This poll is, of course, a snapshot in time, but if an election were to be held that day, 41% of voters would vote Conservative, with the Liberals at 26%, the NDP at 18%, the Greens at 4%, and the Bloc at 36%. A majority Conservative government would form, with Poilievre becoming the prime minister. But when it comes to the popular vote in this country, as we've seen in both the 2019 and 2021 federal elections, the Conservatives won about 200,000 more votes than the Liberals, but still lost the election. So the name of the game really is winning seats and not necessarily about winning more votes. And we will need to wait and watch what happens, since polling is one thing and election results are another. It's also important to note that although the next federal election isn't slated until 2025, the Liberals do not have a majority and must convince at least a dozen opposition MPs to vote with them in order to pass legislation. Based on what we heard coming out of the NDP convention this past weekend, the current confidence and supply deal between the Liberals and the NDP might be in trouble if they can't come to a consensus around pharmacare. Next slide, please. Now, if we shift gears slightly and paint the picture regionally, the Conservatives continue to hold a strong lead in Western Canada, including BC. They lead by 6 in Ontario and by 11 in Atlantic Canada. In Quebec, the Bloc has an 8-point lead over the Liberals. So there's a few points to call out about these numbers that we see here. Firstly, these numbers continue to show the dissatisfaction with the Liberals. The economy isn't doing as well. There's lots of concern around housing, poverty, jobs as being a few of the most pressing issues, so people want change from the status quo. The strength of the Conservative lead also comes from the party's vast improvement in Ontario and BC, along with a significant improvement in impressions of Poilievre. Now, if a Conservative government were to form federally, we still need to keep in mind that this doesn't mean it will be the same political stripe provincially. So they will need to work together to deliver on FPT priorities. And although sometimes it can feel like one election, it's actually 338 elections that are happening across the nation. So the Liberal vote tends to be a little bit more spread out typically than the Conservatives. But if these current numbers hold true, they'd still be in trouble. Next slide, please.
Thanks, Harpreet. So looking at the provincial landscape, we see lots of blue or small C Conservative governments with a few splashes of orange and red. The latest change to this map was in Manitoba, where voters elected a majority NDP government earlier this month. And Premier Webb Canoe and his cabinet will be sworn in tomorrow, and he's promised to implement a bold and aggressive healthcare agenda. The Conservative government in Ontario has 3 years left in its mandate and is navigating a number of issues. They've had recent changes to cabinet, but Minister Sylvia Jones remained in place, and she's implementing some major system reforms, including expanding the use of private clinics for publicly funded surgeries in an effort to cut long wait lists. Quebec's next election is also October 2026. The government there is focused on major health system reorganization, which will end up establish a single health authority, transitioning from the 34 regional health authorities they have now. Maritimes, New Brunswick voters are scheduled to go to the polls next fall, but there's potential to snap election in the coming months over divisions within the Progressive Conservative Government's caucus. Nova Scotia and Newfoundland scheduled to vote in 2025, and Prince Edward Island won't go to the polls till 2027 following the spring election, which saw the Progressive Conservatives return to power. Alberta's election earlier this year resulted in another United Conservative Party government, but a smaller majority than previously. New Minister of Health, Adriana LaGrange, has been directed to decentralize the health system, and we're expecting details of what this will look like in coming months. Both Saskatchewan and BC have elections next October, and Saskatchewan is one of the newest health ministers, as Everett Hindley was moved into the role at the end of August, whereas BC's Adrian Dix is Canada's longest-serving health minister, as he's been in that role since 2017. Now, BC was the first to sign a bilateral agreement with the federal government, which we'll talk about in just a moment. But I'll just ask if any of my colleagues have anything else to add to this map before we move on.
Yeah, I might just say that the provincial map for a federal government, when you think about what it looked like in 2015, it's pretty wildly different. You had more liberal governments. I think you had a liberal government in Ontario, in Quebec, in BC. You now have the NDP with two strongholds, very different dynamic in Quebec, especially when healthcare was a hot topic under Premier Couillard. Those at the Canadian Medical Association that held a conference, Marcel, you'll remember when Minister Philpott and the Quebec Health Minister at the time went head to head on the Canada Health Act. It's a very different political map right now. So it's interesting as we're talking today about how these bilateral deals will go, what will they focus on, what provinces will do what provinces will be first versus last to sign on, how much progress might be made. It's a wildly different dynamic between federal and provincial governments, a lot more productive now in many ways, interestingly, even with less liberal provincial governments. But then to Harpreet's point, whoever forms government after the next federal election, takes place between now and 2025, let's start a pool and see what happens. There are, if a conservative government takes place, this is a tough map to navigate. There aren't that many friendly faces on here as there once was. First, Steve.
That's all right. So next slide. So as I said a moment ago, BC was the first province to sign a bilateral agreement with the federal government coming out of the first minister's agreement on health in February. That deal resulted in $46.2 billion in new funding for provinces and territories from the federal government for joint health priorities. In the weeks and months following that February announcement, all provinces except Quebec signed agreements in principle to secure their share of that funding. So the BC bilateral, the first one we're seeing out of that deal, is based on an action plan which will result in $1.2 billion in new funding over the next 3 years. Specifics of that plan include developing a new innovative model of care at 83 acute care sites around the province, which are mostly hospitals. And government has said they'll use this funding to help implement new nurse-patient ratios they announced in April, as well as recruit and retain physicians. The funding will also enhance access to mental health and addiction services. And the BC government said they'll use this to fund increased number of Foundry centers from 16 to 35. And these centers offer integrated mental health and addiction services to youth and young adults. They'll use the funding to increase access to culturally appropriate health services in partnership with the First Nations Health Authority. And finally, to increase access to digital health records, which we know is a priority of the federal government. So interestingly, this agreement set two hard targets BC must meet by the end of this agreement, 2026. First of all, 50% of family health service providers need to be able to securely share patient information, and 75% of people in the province need to have access to their own health information by that same deadline. So finally, the agreement states that BC will report on progress annually, as public accountability was a priority for the federal government as a condition of this new funding. Next slide.
Okay, so maybe here we're shifting into the discussion last week at the health ministers meeting. But let me just say a couple of words about the BC agreement, which was really, I think, a big win for the federal government and for BC to have that nailed down before this meeting that took place last week. And just about the agreement itself. So as Steve said, some interesting areas of focus for the action plan that BC put together, some new targets that are there. But more generally, a couple of things that stuck out for me. The model for the agreements is very much similar to what was used in 2017. There is just a couple of things I would note. One is that there is a review process that is built into these agreements. That is a two-stage review assessment. Firstly, in a year or two, there's a dedicated process to look at the agreements that had been put in place in 2017 for mental health and home care, and to lay the groundwork for what could be a renewal of those agreements in 2027. And secondly is a broader review a year later that will take place looking at the entire health funding agreement. So that's the 5-year check-in for the 10-year plan. And that will also provide, I think, the federal government and the provinces with an opportunity to do an assessment, a course correction, maybe for the provinces, to identify the need for more funding through the CHT. That's to be expected. So that's a very important piece of these agreements. The second thing I would note is that there's a couple of sets of other bilateral agreements that are in play. Firstly, there is one on aging in dignity that will capture the home care money that was in the original 2017 agreements, plus the long-term care money that had been promised. So those agreements are being developed and negotiated currently, and we should be hearing about some of the first movers there. And then we still haven't seen what the government's plan is on primary care, a little bit of information out on rare disease drug strategy. So there could be some bilateral agreements that follow from that side as well. So bilateral agreements are alive and well, and kind of have become a mainstay of how governments are transacting in the health space. So yeah,
Sorry,
moving
Marcel.
on. Yep, go ahead, Peter.
People are having a hard time hearing you, so you might just need to speak a little louder into the mic. Sorry, just getting feedback.
Oh, okay. Sorry about that. So shifting over to the health ministers meeting, this took place in the context of what was, the last year's meeting of ministers coming together, which ended up in failure. The provinces were not happy that the federal government had not agreed to their terms in terms of health funding. So that meeting ended in disarray. So this meeting, there was a huge push to show unity and common purpose. This was the first meeting of Minister Holland and Associate Minister Sachs. So they wanted to make sure it was a success as well. And the focus was very much on health workforce issues, on data and digital, and mental health and addictions, also touching on COVID-19 and public health more generally. So really important event. I mean, this happens typically once a year or so. The PT ministers got together the day before, and then Minister Holland joined, and Minister Sachs joined them for the main event the following day. And so let's move on into the next slide, which gets into the focus of the agenda. One of the big issues was nailing down some of the specifics on what governments are doing around the health workforce crisis. And there, I would say, there wasn't anything really new here, but they did touch on what are some of the key areas of action right across the country. Retaining nurses. How do you educate and train the workforce for the future? How do you accelerate foreign trained professionals to come and practice in Canada? The idea of a pan-Canadian credentialing approach that allows doctors and nurses to practice outside their jurisdiction where they were originally licensed is moving ahead as well. And then an important data piece that CIHI is spearheading to get better data and analysis and leading to better policy and planning around the health workforce. So those are really key things. I mean, I think there wasn't really anything new here, but it allowed ministers, I think, to show unity. They did meet with some of the major national health provider associations before the meeting to show, a really strong sense of solidarity with the work ahead and the challenges that frontline providers are facing. Maybe I can just turn quickly to Harpreet and Steve if they want to add something on the sort of provincial angle to this.
Yeah, definitely. Thank you so much, Marcel, for that overview. As it relates to HHR, the Ontario government has already rolled out a number of initiatives to tackle this crisis. In fact, much of what we see on this slide as the top priorities, Ontario has already identified and developed some sort of plan against. Earlier this year, the Ontario government outlined the province's plan to reduce wait times and backlog for surgeries, procedures, and diagnostic imaging through the expansion of independent health facilities and privately delivered OHIP insured services. As for labor mobility, this is also something which is top of mind for Ontario, and the government implemented the As of Right rule in July, in which they became the first province in Canada to allow doctors, nurses, medical lab techs, and respiratory therapists registered in other provinces and territories to start working immediately. Ontario has also looked into expanding the scope of practice as another means to improve HHR. And as an example, about 2 weeks ago, 6 more common ailments were added to the previous list of 13 as ones Ontario pharmacists can diagnose and prescribe medication for. There's also been some thought given to the future. And when we look at building a strong pipeline, Ontario has committed to building new hospitals and upgrading existing health infrastructure. The government is also expanding medical school education through adding additional seats to existing programming. There's been discussion provincially about introducing programming to recognize the foreign credentials of healthcare professionals to allow them to practice in Ontario. This would be significant as there's a growing number of Ontarians without access to family physicians or primary care. And we heard during the meeting, Minister Holland did mention a 90-day turnaround program to be implemented to achieve this. So looking forward to hearing more about that. But all to say, these are a few examples of the work Ontario is leading or already doing or committed to. None of these priorities are net new, and every jurisdiction, I think it's safe to say, recognizes their healthcare system is stretched and exhausted, but is still figuring out how to implement something that works to alleviate that burden. And a successful model doesn't currently exist to replicate across jurisdictions, but perhaps that's something that we can keep our eyes open for. I'll hand it over to you, Steve, to provide some perspective around Western Canada.
Sure. So, of course, HHR top of mind for all health ministers, certainly here out west. And BC, like most provinces, has had challenges with access to family doctors, which is why it was significant last year when BC Health Minister Adrian Dix announced last October that the government, doctors of BC and BC family doctors had agreed to a new payment model for family doctors to attract and retain physicians in family medicine. And as opposed to strict fee-for-service, the new model takes into account several factors, including the time spent with patients and complexity of issues they're managing, as well as the overall practice of the physician and administrative costs. And looks like it's working. The minister announced in July that over 3,300 physicians had signed up for the new payment model, and they're hoping this will help provide increased access to the family physicians here in BC.
Okay, thanks, Stephen Harpreet. Moving on to the next slide. So data and digital health was the second major thrust, I think, of the meeting, and something the federal government really was trying to rally support around the PT table. So it was, also similar to HHR, also referenced in the funding agreement last February, also referenced in the first bilateral agreement with BC. These things are all embedded in there as a common expectation that all PTs working with the federal government will try and make some headway in these areas. So this is all about, collection and sharing of high quality data, getting faster to interoperability to allow health providers to share data across settings, across jurisdictions, getting better alignment in policies across the country. There's also the concept of a health data charter that is been supported by provinces and the feds, and then doing a better job at sharing public health data on COVID-19 and other public health challenges. So nothing really new there in terms of what had already been discussed. They did package this into a joint FPT action plan, which kind of elevated the importance of this set of commitments. And there was also the interoperability roadmap that was unveiled last spring by Canada Health Infoway, and that has been now endorsed by all provinces except for Quebec, which serves as a fairly detailed game plan for how jurisdictions are going to work towards interoperability of systems over the next 5 years or so. So again, nothing really new, but a lot more in terms of momentum building and getting everyone on board with a really solid game plan here. Anything to add on this, Harpreet or Steve?
I would just say for Ontario, this very nicely matches up with what we currently have in place. We're expecting some sort of new digital health strategy to be released soon, but if we reference the last one that was released in 2019, it really represented a shift in prioritization. So, away from the thinking of back-end systems and towards more of a retail experience for Ontarians. So the core priority for the government was that they wanted Ontarians to feel like their healthcare system is as convenient, responsive, and flexible as something as similar, let's say, to the banking system. So with access to their information. And this matches up nicely with what we're hearing from the federal government's goal of providing Canadians with access to their own health information and health data. So I think it feeds in nicely to sort of the plans that have been laid out here provincially.
And here in BC, I know that BC launched the Health Gateway mobile app last year, building on their Health Gateway patient website. This allows anyone to instantly access records related to prescription medicines, lab results, immunization records, physician visits, and they're planning to add diagnostic imaging and clinical documents, details of hospital visits. They said at the time that 1.2 million British Columbians were already using the website, and given this is now an app, I'm sure the number is much, much higher. And this strategy is likely why BC was confident to commit to 75% of the population having access to health records commitment in the action plan.
Okay, thank you. And then moving on to the next slide.
I think I'm jumping in here. Wanted to talk about a couple of things with mental health and addiction. So this is one of the bilateral agreements that has yet to come. And it's an interesting one because in the 2021 campaign, the Liberals at the time in the election said that they create a dedicated mental health transfer, which really did create a lot of excitement, I would say, in the mental health community. When I go back to 2016, 17, and there was that initial commitment, 6 billion for mental health, 5 billion for home care. I always get those backwards, 11 billion total. But to have that dedicated funding just for mental health was an incredible moment for the mental health community to both be recognized and have targeted funding flow right through to provinces and territories that would support support the mental health community. So while there isn't a direct transfer in the way that there's a Canada Health Act, I think that's probably, when I read the platform, that's what I read, was that there'd be a Canada Health transfer, but for mental health. That's the impression that was left. Well, there isn't that. There is going to be a dedicated transfer of funding specifically with a bilateral deal. So I think that the government can keep to their commitment. But a lot of that work, it's up to provinces and territories to target, focus, invest where needed. The federal government has two big things that they've been working on: a suicide crisis helpline, which was an initiative of a private members bill, which has come about. I believe Conservative MP, I want to say Rob Moore, but I might be getting that wrong, so I should probably hold my tongue. And then another product that the government of Canada has really invested a lot of their time and energy in over the last couple of years is Wellness Together Canada, which they will point to as the big thing that they do. But the reality is, a lot of this is more funding going to the provinces and territories to support them. Anything from my colleagues on this before we talk about the next one? The next one. Let's go to
just say,
Peter.
Peter,
go ahead,
that
Steve.
BC is really working to add mental health and addiction supports amidst continued lives lost to poison drugs out here. We're 3 years into a 10-year strategy for mental health and substance care use. BC's taken a number of actions, but unfortunately, the annual number of deaths continues to grow. They've increased the number of boundary centers and taken a number of other actions, including working with the federal government to decriminalize personal possession of certain illegal drugs. They had to tweak those regulations last month, make possession of those drugs around parks and playgrounds illegal at the request of municipalities. My prediction is, unfortunately, that while they're going to continue to work to increase add resources and welcome new investments, this will continue to be a challenging file here in BC.
Thanks, Steve. And thanks, Alex, on the chat. Todd Doherty is the private members bill sponsor, not Rob. My apologies. Okay, let's flip to the next slide and talk about the thing that was not on the formal agenda. And we also have Marcel. We had Marcel with us, who ran the secretariat when pharmacare was studied by the federal government. So I might just start by saying that this will be a very interesting test of the Liberal NDP supply agreement. And by say test, I mean not whether or not they can withstand it, because I think they will. But how the two parties will work together if they truly want to maintain this relationship, because the two parties are not in the same place on this particular file, and the wording of the supply agreement between the Liberals and the NDP all but identified the fact that there was a gap between the two parties on where they'd want to go with this. So if you recall the supply agreement, it was very prescriptive on what would happen with dental care in the first year and then the second year and subsequent years in terms of eligibility and how much would be going towards it. It was very prescriptive. When it came to pharmacare, it would just be that a pharmacare bill is passed by the end of 2023. And that would, you would assume that means that the NDP would support it. If it passed and they needed the NDP support to pass it, then the NDP would be supportive of it and it would meet the terms of the agreement. But it was silent on policy. And I think the elephant in the room for all of us since 2019 is, well, what is the model that the federal government would support investing in? And how are they going to navigate? I would argue, the most important stakeholder, obviously, for governments is the people. But as a function of government, one of the most important stakeholders for the federal government is provincial and territorial governments, because they deliver care. And there's not that many paths forward for the federal government, in my opinion, on this, because if they try something wildly prescriptive, I think it'll end up in the courts in Quebec on a constitutional basis. But that might not meet the needs of the NDP. So we're stuck between a rock and a hard place. By we, I mean the government. And you can see that teasing and playing itself out in the media, because the NDP want to hold the line. They want to make sure that they are clear about what they want to see in this bill. And for them, it is, if not single payer today, a clear, dedicated path to single payer at one point in time. That's the line that the NDP are holding. And this government has released themselves, and also with the benefit of the PBO, an assessment of how much something like this would cost. I might stop there, Marcel, and kind of get your thoughts on, what are there any differences between how pharmacare is being viewed fiscally now versus when you were working on the Hoskins report secretariat? And then if you have any thoughts on, what is in the art of possible if you're looking through the lens of what would it take for provinces and territories to say, okay, I will negotiate a bilateral on that.
Well, the big difference, I guess, between now and 4 years ago is what happened with the pandemic and the huge debt that the government has added to since then. Hundreds of billions of dollars more in debt than they were. Big new initiatives that are very costly in childcare and dental care, and that leaves very little fiscal room, I think, particularly if the economy is slowing down, maybe stagnating. PBO just said earlier this or last week that the federal deficit was still in the mid 40 billions for next year. Those are very high numbers, and seems to me unrealistic that you might see in this legislation an all-out commitment to a single payer system when the numbers in terms of debts and deficits and fiscal framework just don't seem to point to that as a realistic outcome. But they may be able to finesse it by somehow pointing to a phased approach, not closing the door to a single payer, but not outright committing to it out of the gate. I think that would be not credible, and also would upset some of the provinces, I think. I mean, the provinces are the majority payers of drug coverage in Canada right now, or at least the close to the majority. About 44% of drug spending is PT spending. So they're not about to upend their systems of drug delivery for a few extra $billion. I mean, maybe if the federal government were to come to the table and say, yes, we'll cost share with you, or we'll put, an order of magnitude, 10, $15 billion. I just don't see that happening, though. So I think the provinces, what's really important for them, though, is whatever the feds say they want to do, it's got to be backed up by a really credible funding commitment, not something that could be yanked away, easily by a future government, because the provinces will be left holding the bag with their populations expecting a continuation of drug coverage. So really difficult spot for the federal government to be in. And I guess we'll see how this unfolds as they make their first attempt with this draft pharmacare bill.
Well, you know what they say, Marcel, when the going gets tough, the tough bake in the legislative review. Right. So it's not. I mean, I don't know if they say that, but that's pretty standard practice. So medical assistance in dying, when there was a court decision that required the government to move, they had to do legislation. They had to allow for it, but there were a number of different situations that it was politically challenging to navigate, nor was the evidence available. So the government baked in a 5-year review. When cannabis was first brought in, and it was new in the global stage, and it's hard to know where it might go. What do? You bake in a 5-year legislative review. So if you have an NDP government or not NDP government, if you have an NDP who have said this is their line in the sand, but it's not something that has to happen today, it does leave room for the government to bake in a 5-year legislative review to take a look at the evidence and the possibility of expanding and working with provinces and territories over time. So I don't think it's that complicated. But from a legislative drafting standpoint, it's just what do you put in legislation that gives the NDP enough confidence that they can go back to their base and say, we got this, we didn't lose on this. And that's what I'm really curious to see how this back and forth goes between the Liberals and the NDP, because at one point they both need to declare that they won in order to get through this and for the supply agreement to hold up to the end of 2025. If one publicly feels like they're losing, that's not good for them. So that's the thing that they need to navigate while they're navigating actual policy, while they're navigating what provinces and territories want, and while they're navigating what Canadians care about right now, which is predominantly the price of groceries, inflation, price of gas, and surgical backlogs and HHR, and not necessarily this. Harpreet and Steve, anything
So
from your perspective in the PTs?
Yeah, I
I'd
would
add
say,
to that sorry,
go ahead, Steve.
go ahead, Harpreet.
Thank you.
Here, I'll
Peter,
choose Harpreet.
thank you. Peter, I would say that for the current Ontario government, I would imagine there to be likely little appetite to accept a drug insurance plan that's so broad-based. I mean, if we take a look historically, when this government first came into power in 2018, one of the first things that they did was dismantle OHIP Plus. And, you know, as a recap, under OHIP Plus, the youth pharmacare program created by the previous Liberal government provided every resident age 25 and under to receive free coverage on more than 4,400 medications. But the Ford government changed this to only provide coverage for those that are not covered under another insurance plan. However, with that being said, I do believe that if the federal government is willing to foot the bill here, then I can see the Ontario government accepting some sort of expanded coverage. I think, you know, it stands true for other jurisdictions, and this was one of the things mentioned in the presser following the meeting, is that Ontario will want to do what's best for their specific context, their specific needs, their population. So it's something that, you know, we will need to sort of wait and watch. But I wonder how it'll pan out for the different jurisdictions across Canada. But Steve, very curious to get your take as well on this.
Thanks, Harpreet. Building on that, I'm not sure there's enough appreciation just how different the drug plans are across the country. Here in BC, we cover a large amount of the population. It's income-based, and they've worked hard. They've invested to try and adjust those deductibles to ensure that people who need access can access them. However, BC is one of the smaller formularies and typically takes the longest to add drugs to formulary. So Minister Dix has said very clearly that any new obligations that the federal government puts on the provinces will need to be met with new money. Otherwise, they'll face some opposition from the provinces. But coming up with those plans that match those different federal dollars, match those different plans, and either fill the gaps or do that with provincial jurisdiction and match those issues will be, I think, a challenge.
Thanks, all. I think we'll pause here and continue and come back to some questions that I see in the chat, but we'll finish off a couple slides here and then get into some of those questions. There are a number of public health priorities. The one thing I was thinking of here is one, there has been a lot of work on biomanufacturing and life sciences, more from the perspective of the government of Canada and provinces recognized that Canada did not have robust supply chains when the pandemic hit. And they didn't necessarily have robust processes to invest in supporting new supplies of priority devices, drugs, whatever it might be. So the BLSS really helped focus the government's energy in having those secure supply chains and is starting to think through with provinces and territories and others, what do we as a country need to do to prepare for whatever that unknown pandemic or emergency that will inevitably hit. And that's a heck of an unknown to operate in. And it's not lost on me that while we're in a pandemic or while we were in SARS, I know there's a couple people on here who have worked with David Naylor in the past. There's a lot of attention on public health, but the moment we're out of the crisis, it goes away. So this is one of those things where I think we thought it was worth mentioning because there is some stuff happening, especially below the line on those supply chain resilience. There's this broader, public health is important until it's not, and then until it is again, and that cycle seems to be continuing. But it was a topic that ministers highlighted. I can't help but feel that it is often more of an afterthought than it ought to be, frankly. Comments from my colleagues, especially if I overstep there?
Maybe all I would add is...
Oh, go ahead, Marcel.
Yeah, I mean, it struck me that this was a relative low visibility item on the health minister's agenda, given what we've gone through over the past 3 years, basically an existential threat that we've gone through, and surely some lessons learned, that could be the focus of some really focused joint work between the feds and the provinces, to better prepare for the future. And there was not much that was said about that. We're not quite out of the woods yet. But I think it just comes down to, it's, politically convenient not to put a huge spotlight on this right now. And yes, it was on the agenda because people expect it to be on the agenda, but there really wasn't a whole lot coming out of this discussion that I think would warrant, not as much as the nature of the crisis would warrant.
Thanks, Marcel. Okay, we'll flip to the next slide. I think, oh, sorry, Taryn, is the next slide not the slide, is the new slide. Oh, it's not there. We did have a slide that we wanted to talk through, and I'm actually just going to pull it up because I can verbally walk through, because we wanted to really help you understand, okay, we just talked through family health services, surgical backlogs, health data. Those are big conceptual ideas, but what are governments driving towards? So there has been some communication back and forth with the government of Canada and provinces, and for those that work with us more closely, you'll be aware of some of these things because we've been watching them for some time. But if you want to get a sense of, well, what are governments driving towards right now? What does the federal government want to drive towards? And this concept of health indicators is something that was trialed out in 2016-17 to start collecting data on what the money's going towards and how it's improving. So to give you an idea of what governments are hoping the funding for these categories of spending will achieve, indicators would include the percentage of Canadians who report having access to a regular family health team, a family doctor, a nurse practitioner, including in rural and remote areas. Being able to capture that in order to drive policy decisions in where investments might be needed to up that. Tracking the size of the COVID-19 surgical backlog in order to be informed to make better policy decisions. The net new number of family physicians, nurses, and nurse practitioners. And I know there were some questions in the chat here getting to some of this. So being able to identify and track and report out on that to, again, support better policy and spending decisions. On mental health, driving towards understanding the median wait times for community mental health and substance use services, the percentage of youth from 2012 to 25 with access to integrated youth services for mental health and substance abuse. Again, really focusing in on youth as a starting place for targeting that funding, as well as the percentage of Canadians with mental health order have unmet health need, unmet mental health need. And then on health data, the percentage of Canadians who can access their own comprehensive health record electronically, and the percentage of family health service providers and other health professionals who can share patient information electronically. So this list of indicators is a starting point. So when you want to develop a base of data, if you want to start tackling a problem, this is what the federal government, at least from a tracking standpoint, believes is the right place to start. I'm not sure if others want to comment. The only thing I'd say is that this is a starting place for indicators, and it's likely that more indicators will be added over time as systems to collect data and report on data, as well as trust between those who have ownership over the data and governance over the ownership over the data is established and improves.
The only thing I'd add, Peter, is that in the BC Health Agreement, as Steve mentioned, a couple of the indicators that are being targeted there on access to health data and some other things. So they basically have, for each of those indicators, laid out what their target is as a province. And so I think that's a significant change from the level of detail that was provided in previous agreements. And it'll be interesting to watch as these agreements roll out across provinces, what other provinces are going to say is their target for each of those indicators. And then to kind of roll that up to get a sense of, is there alignment in terms of how quickly jurisdictions want to achieve change.
Thanks, Marcel. I think we're going to turn it over to Harpreet.
Thanks, Peter. I'll get started and then hand it over to Marcel for his perspective as well. So if we take a step back and really try to digest all of this information, there are a couple of key takeaways for us. Firstly, if we look at the landscape, we know the federal government needs tangible policy and funding wins. A Liberal government simply can't win re-election if they're losing on both the health and economy front. We also learned that the need in health is great, but the fiscal outlook looks grim and leaves very little room for net new investments. Governments are already struggling to allocate what they have for healthcare in areas that need it the most. And since being elected in 2015, the federal government is now working with considerably more left-leaning governments. This creates both opportunities to collaborate, but also challenges to meet expectations. When we look at collaboration, we can expect this to be ongoing in nature. With BC signing early, it's the stage for more bilateral deals being signed has been set. It's not a matter of if, but rather when this will happen. And at the HMM meeting itself, the tone between governments is far more collaborative than previous years and what we've seen. So twice in recent years, the meeting ended in disarray and politically charged press conferences. So it was a very different tone this time around. However, when we look at everything that was covered and discussed, a few things were certainly missed. Firstly, the expectations from stakeholders on the rare drug strategy are still quite high, with very little progress being made from the government, despite the $1.5 billion announcement. And the government must continue to negotiate on pharmacare to achieve some sort of consensus and happy medium that works. But happy to turn it over to you, Marcel, to add anything else.
Yeah, the only thing I would add is, I mean, when you take the funding issue out of the equation, that has been settled now. It's interesting how collaborative governments can get and roll up their sleeves and make some progress on some really important issues. So that's really, I think, a big takeaway. Quebec is there at the table, but those of you who would look at the the communique and the backgrounders will see that they have an asterisk at every occasion that says, healthcare is in exclusive jurisdiction of provincial governments, and Quebec is not, endorsing or signing any agreements that have conditionality attached to them. So that will be interesting to watch in terms of how the bilateral deals roll out. We don't have one for Quebec yet. They haven't even accepted in principle the federal offer. So that is something to watch. And then, of course, pharmacare and I think dental care too. We haven't really seen the full breadth of FPT concerns or conversations around how that's going to roll out. So those are potential flashpoints going forward. But I think generally on the health file, the federal government is in a much better place than it was at this time last year. So that helps them as they get closer and closer to an election, and provinces, continuing to do their work and can benefit from that collaboration as well. So back to you, Peter.
I might just add, well, there's a couple things that, and I'm seeing in the chat, there's a couple of people that are commenting, and I meant to speak to this during the pharmacare slide. So there are a couple bilateral agreements that are either in the works or potential, and we've only seen one of them so far. British Columbia is the first to sign on to one of the bilateral agreements that we outlined here. The second one would be around mental health and addictions. No one signed on to that bilateral agreement so far. The third would be around rare drugs and the drugs for rare diseases. That's something that is not, our understanding, currently part of the ongoing formal negotiations. It looks like provinces and territories are focusing on those first two. And then any future bilateral agreements would likely be pharmacare and the rest. But there are three on the docket right now that the federal government has money allocated for today. And the funding would also extend, renew, ensure that the funding that was put in place in 2016-17 does carry on for the additional 10 years. So it is a bit complicated because there's a lot going on. One of them focuses on mental health, the other focuses on aging and dignity. There is funding in there for long-term care, for home care and community care, funding that existed before that would be topped up and added on to. And then there is this big question of when will provinces and territories and the federal government show tangible movement on the 1.5 billion that is being set aside for rare drugs. So there's no shortage of opportunity for further funding and bilateral deals. It's just how long can we go, and how much progress can be made between governments to land a deal and have that funding flow. So I think this is the beginning of progress. BC signing on to one, but that's one of three that we know of right now. And there are 10 provinces and multiple other territorial agreements as well too. Okay. Should we tackle a couple of questions, team, with the last few minutes that we have here? A couple jumped out on me that I wanted to throw forward. There were quite a few questions on pharmacare, so I might tackle that for a second. A question from John around insights as to how conservatives view national pharmacare, and said that they heard some sound bites, but no comprehensive strategy on the issue. I would say, from my perspective, if you're talking to a conservative MP or member of the conservative leadership team, they fundamentally believe that the federal government's role is to financially support provinces and territories to make the decisions that they feel best for their jurisdiction. I think it would be very unlikely that there would be a dedicated pharmacare initiative by a conservative government. I think that the federal conservatives, if they form government, would ensure that there is enough funding flowing through the Canada Health Transfer and the rest. And the leader of the Conservative Party did commit to continuing the agreement in principle, the funding that we've been talking about today, if they do form government. But I'm not keeping my eyes peeled too open for a conservative pharmacare plan, because I just don't think it's in the cards. Any others have some thoughts there?
Yeah, I think you're bang on. I think the only thing that might survive is the rare disease drug strategy and the money that's been allocated there. I don't think they would roll that back. But I don't think they would then kind of go beyond that.
There are a number of questions about models of pharmacare. What happens with the private payer system? What happens with getting best bang for government's dollar when they're buying drugs? A lot of these questions are really great questions, and it really comes down to what model a federal government chooses. And Marcel and I have gone back and forth on this. A good way for you to kind of encapsulate what a federal legislation could be on pharmacare, that would pass muster to provinces and territories. It would likely detail the minimum criteria in order to get funding. So, and Marcel, you can rhyme them off better than I could. But what is the maximum copay? Are there acceptable out-of-pocket costs for communities? Is there a formulary that a minimum formulary that a public insurer needs to have? There would be questions around how does this impact the private system? These are all fantastic questions that none of us have the answer to until the government comes out and says this is what we believe in, because it's a complex board, and once you change one thing, it can have impacts on another thing. So it's not a clear-cut answer. So until we start seeing some details in terms of where the federal government wants to go, it's really hard to answer some of these questions. Marcel, I don't know if you want to jump in on that.
Yeah, I don't have any sort of inside knowledge of what's happening there. And I think, it's a difficult balancing act, because, the government knows that private plans are, the main way that Canadians get access to drug coverage. So they need to be careful what they say about that. They need to be careful, I think, not to tell provinces that they're going to have to shift their whole approach to delivering drug coverage, to the one size fits all approach that the government is thinking of, if it's thinking of a single payer approach. So they need to navigate those particular issues, which I think is quite challenging. And I think that, if they leave some room so that there is some money that's available, and that they can start, provinces investing in the same way PEI has done with some a pot of money that was set aside a couple of years ago to expand the formulary, to reduce co-pays, to expand eligibility for provincial drug plans. They can actually connect, additional federal dollars to improvement in coverage, which has to happen under any approach, really. You have to find a way of filling that gap. Now, the big question is, do you keep going after that and completely fill the gap and then displace private insurance so that you get to a private, a single payer plan? Or do you stop with, just a filling the gaps approach? And the only thing I would leave you with is, and proponents of a mixed payer system don't always get to this, degree of specificity, but you cannot achieve a universal drug coverage plan unless there is some kind of mandate that is given for coverage through either a public or private plan like Quebec has done. Otherwise, you're stuck in what Obamacare is in the US, where you're trying to fill the gap of people who are uninsured and not coverage, but you haven't given a mandate. So you'll always have people that are not covered by a public or private plan. And you also create some perverse incentives as the public plans become bigger and more comprehensive and cover more people. You also create an incentive for employers to dump their employees onto the public plan. So that creates, unstable, an unstable environment for drug coverage. So those are the sorts of things, those are the sorts of details that need to be worked out if we want a mixed payer system to actually lead to a universal coverage system. And that requires regulation of private plans, something that provinces up to date, except for Quebec, have been unwilling to do.
Just to close off pharmacare, somebody asked about affordability of drugs, or how do you get best price, and there are structures in place already. The Pan-Canadian Pharmaceutical Alliance, which really is a beast of provinces and territories, the federal government signed on later on. They collectively negotiate drug prices to try and achieve savings. So that's another good point, that the affordability of drugs and the accessibility of drugs aren't necessarily the same thing, and they require their own approach as well too. And it's very easy for us to conflate all these things because, again, there's been no definition to this. I might close off. There's lots in here, and for those who didn't get their question answered, please feel free to reach out to us, especially if you want to follow up and ask questions. We're more than happy to engage. But there is one question I thought that really is tied to the bilateral deals. Somebody asked about funding regarding for aging in place, other than status quo, any relevant funding on long-term care, home care, community care. There's lots here. So I don't know, Marcel, if you want to take a stab at trying to summarize some of the funding in those places between the 16-17 accords and what's in the latest round.
Yeah, so there was the $5 billion for home care in 2017. That is being delivered over 10 years, finishing in 2026. So that hasn't changed. There was no new money added for home care. On long-term care, there was money added for the Safe Long-Term Care, around the Safe Long-Term Care Initiative, and during the pandemic, I think it was $3 billion. So we haven't yet seen what the arrangement will be for that $3 billion. There was an amendment to the initial round of bilateral agreements for an extra $1 billion for long-term care. So there's these, dribs and drabs, not dribs and drabs, they're actually pretty substantive pieces of cash. But all of that needs to be brought together into one single bilateral agreement that will be framed around this idea of aging in place. And as I understand it, those discussions are ongoing with each province and territory currently, with a view to getting those nailed down in the next few months as well. So that will be interesting to see how that materializes. And I think the review process that has been built into these agreements, as seen in the BC agreement, will provide an opportunity for stakeholders that are interested in more money for home care, for example, to make their case around the time that governments will be looking at these agreements and doing a course correction for the next round.
On behalf of our team here, thank you for joining us. We're right at 3. These are always fun. Steve, Harpreet, Marcel, really appreciate being able to do this here with you today and for such an awesome group of people that listened in. So thank you so much and have yourselves a great day.
Bye, everyone.
Thanks, everyone.